Okay, so let's get started. So really it's an update on our project, and I don't have all the researchers on here, but it's a few pharmacists from across Canada. So we have Judith Marin in Vancouver, and Kelly Orsolak in Manitoba, myself in Ontario, and Joanne Wilson in Nova Scotia. And we also have a few nephrologists, Monica Bullia in BC, Claire Baum in Manitoba, Amit Garg in Ontario, Cello in Alberta, and then a few patients as well. We have Leah Getchell, that some people probably already know, and she's from London, and as well as Blair, who is in Winnipeg. So we actually had a productive meeting last week, and so I'm going to update you on the project itself and some of the updates that came out of last week's meeting. What I'll do is I'll give you a few definitions and tell you a little bit more about polypharmacy and dialysis patients, what really deprescribing means, and then before we get into what our goal of the CANSEL study is, I'll give you a little bit of a overview of the results of our pilot study that we did in our dialysis unit a couple years ago. So polypharmacy means many drugs, and some of the literature describes it as five or more drugs in one day. It also means inappropriate choices of medications or doses, and in fact, as Adira said, many patients take many medications a day, and hemodialysis patients take an average of 15 medications per day. Those are the number of medications, not the number of doses. Some people are taking, medications 2 or 3 times a day, and so you can imagine that the number of medications in one day really adds up. So deprescribing, the term is defined as the process of tapering, stopping, discontinuing, or withdrawing drugs with the goal of managing polypharmacy and improving patient outcomes. It's been associated with fewer referrals to long-term care facilities, lower drug costs, and also decreased mortality. And really, it improves the patient's perception of their global health. So why should we deprescribe in hemodialysis? Well, we already know that patients on hemodialysis have a high pill burden, and much of the evidence for efficacy of many of these therapies is lacking in this population. There's also safety concerns for medications because many are cleared by the kidney and some are not even removed by hemodialysis, so we worry about accumulation. And there are no tools for deprescribing available for this population. This would be new. There are some tools available to the elderly population, but none have been developed in the hemodialysis population. So I'm just going to quickly go through the study that we did in our unit. So what we did is we tried to develop some deprescribing algorithms. Then we wanted to determine the effectiveness of these algorithms as we incorporated them into current practice, and then in that we monitored patient safety and satisfaction when we implemented our algorithms. So how do we do that? First, we needed to know which medications we thought we should deprescribe. So we did a literature search. We had an idea of a handful of drugs that we thought really didn't have great evidence for its use in dialysis. We conducted some focus groups to get healthcare perceptions of what we were thinking was right about the medications, and we reviewed 50 charts to see how common these medications were. And so we came up with 5 target medications that was based on our little chart review and literature searches. And these 5 medications were selected because of poor evidence for patient safety and lack of evidence for efficacy. So the 5 drugs were diuretics, so something like furosemide, proton pump inhibitors, so that would be something like Losec or Pantalog, quinine, which some people still use for leg cramps, alpha blockers, this would be used for benign prostate hypertrophy, and sometimes people use them for blood pressure. This is an example would be taurazepam, and statins. And I highlight statins because we know that some patients really do need them if they've ever had some type of heart event, like a heart attack, then they are indicated. But for primary prevention in dialysis, really the evidence is quite weak. And if you're older, you know, you have many more medications, and really we're not sure of the benefit in someone who is over the age of 80. So that's why it started. It was done in someone who was the age of 80, who was on many medications and really wasn't up to taking all their medications. So we developed specific algorithms for those drugs. Then we needed to validate it. So faith and content validity was assessed through 3 different cycles. So we met with nephrologists, pharmacists, and nurse practitioners in our unit 3 times. So we met with 5 different healthcare providers, received feedback on our algorithms, and then did that 3 times. And then it was ready for implementation. So we did an observational pilot study. We did it at the Toronto General Hospital, and this was a couple of years ago. And it was over almost a whole year period. So how did we do this? So we collected the best possible medication history, and that really means we did a good review on the patients. So pharmacy, so it could have been a pharmacist, a pharmacy student, reviewed with each of the patients their medications. And this had happened over a summer where I had extra students to help. We targeted, if we identified one of those target medications, we then looked at our algorithms that we had developed, informed the whole medical team, and decided if we should actually go through the algorithm and deprescribe or stop the medication, and we consented the patient. We communicated this with the patient, and we monitored symptoms according to the algorithm. So, for instance, if they were on a diuretic, we would monitor their blood pressure, their intradialytic weight gain, and potassium. So after we implemented the deprescribing of the drug, we actually followed them for a few weeks, but then we followed them up 6 months later. We thought if we stopped the drug, you know, a month later, if they had started it, what good had we really had done? So we wanted to go back 6 months later. So what our primary endpoint was to look at the portion of target medications successfully deprescribed, and then our secondary endpoint was to look at, you know, average number of meds before and after the intervention. Were we successful? And we measured patient safety and satisfaction by really asking them about different symptoms that they would experience by stopping the drug. So for PPIs that we use for acid reflux, we would ask them about, you know, did they have any type of symptoms before we stopped it and then after, and we calculated on average how often that was happening. Okay, so I won't go into the results of each and single every drug, but overall, I just want to give you a big picture of what happened. There were 240 patients that we interviewed. We excluded 169. 109 were taking one of the medications for a valid indication. So that was mainly statins. Or they were not, only 60 of them were not taking one of these medications. So we approached 71 patients, and we excluded 36. I'll get into some of the reasons why. We recruited 35, and we were successfully deprescribed in 27 of those patients, and at 6 months, 25 of them. Okay, so baseline characteristics of these 35 patients. They were average age of 65, very typical of our dialysis population, 21 males, 14 females. They had been on dialysis for a median of 40 months, so just over 3.5 years. And you can see they were on total of 13 medications. And the typical comorbidities are captured here: hypertension, diabetes, cardiovascular disease. So we were successful. 77% of medications were successfully deprescribed. The average number of medications hadn't really changed, probably because we had a small population. But we did measure patient safety and satisfaction by interviewing them before the discontinuation and after. We didn't have a formal survey, but we specifically asked about the symptoms that were associated with each of those medications, and patients agreed that they were feeling better or, you know, didn't need their medication after all. So we were able to validate these algorithms in our unit. It helped definitely guide clinical practice, and at the end, it really did increase awareness of inappropriate medication use in our patient population. Some limitations which we'll lead us well into our CAN-SOLVE goals. The single-centered, patients may continue to use these medications at home when we're unaware. Maybe a new medication was prescribed in the meantime, and we didn't follow long-term clinical outcomes. So for diuretics, it would be important to look at heart failure admissions. So it is feasible. We were able to do it with essentially the manpower that we had there. We brought these algorithms into routine practice as we perform medication reviews in all of our patients, and we were able to monitor these symptoms while they came to dialysis. It definitely increased patient safety, and I think really where we're leading now to is try to implement these in more centers across Canada and really study the outcomes better. So what's our CAN-SOLVE overall goal? It's to improve current clinical practice by decreasing polypharmacy in our units. And we think this can be achieved by developing these deprescribing algorithms for medications that lack evidence for efficacy and safety in this population, using a systematic national evidence-informed consensus building process. So our three main goals is to assess and compare demographic and medication use patterns in hemodialysis patients across Canada. So I'm going to share with you the results of that since that's completed, and to develop new deprescribing algorithms and build upon the current ones that we validated in our unit, the 5 that I showed you. And then we really need consensus for this to really work. We need consensus from across all practitioners across Canada. So we're going to try to do a modified Delphi approach to really understand how these algorithms will be used in practice. So the first objective I'm going to share with you now. And so this is just showing you medication use in Ontario. So when I had done our pilot, we looked at our own charts and had to try to get a sort of feel of what medications were being used that we thought maybe were being used inappropriately. But to confirm that, we looked at a database in Ontario, BC, the Promise database, and Alberta, and Manitoba still working on theirs, but essentially wanted to confirm that the medications we thought that potentially could be used inappropriately were actually being used. And lo and behold, of course, you can see here that statins, PPIs, diuretics, opioids, benzos, warfarin, allopurinol, some antidepressants, alpha-adrenergic blockers, and anticonvulsants were the highest. So those are basically our top sort of 12 drugs that were being used consistently in our province. And we know that there's not great evidence for some of these medications, or potentially they have the risk of being used inappropriately. So after doing that, we decided that we needed to agree upon, so we have data from our databases showing us the top use, but we really want to decide which ones we want to actually incorporate into algorithms. So when we met last week in Montreal, this information was brought to our group. It was emailed out beforehand. We had two conference calls beforehand to discuss the top 12 medications, and everyone was to come to Montreal with a goal in mind to, which ones, top 6 to 8, maybe even up to 10, would we want to develop algorithms for, and the pros and cons of developing an algorithm for each one of those medications. So those were the top 12. So it was no surprise to many of us when we did do this database analysis. And when we did our poll, can we just go back to that last slide, sorry. So this was actually the digital poll of the top 12 drugs, and you can see PPIs were number 1, and you can see warfarin and opioids were number 11 and 12. And as a group, we had decided that we wouldn't want to develop deprescribing algorithms for warfarin and opioids right off the bat, as we knew that was very complicated. There were a lot of decisions that go into choosing those medications, and opioids on their own for pain would need a whole other project on itself. So those two were pretty much so eliminated, and as you can see, they became sort of in priority of which ones we should stop at the end are the last ones. So we decided on these top 9. So I didn't have prokinetics in there, but we had discussed it in Montreal that we should add it. And so when we did our poll, you can see that these are our top 9, and decided that we would go with the top 9 to develop algorithms. The ones in green are the ones that were developed at our site a few years ago, and so they will be included. And so we have 4 more to work on this summer. So I have a research student for the summer that will be working on these algorithms using literature and interviewing healthcare providers in our unit to develop these algorithms. So that's where we're at over the summer. The reason why we went with 9 was we thought when we do our modified Delphi approach, our national consensus, hoping to do it start it in the fall or start the process in the fall, is that we would think that maybe a couple of these, the group may decide shouldn't be algorithms, or maybe not use these algorithms at this time. And so probably, we don't know what will come out of it, but we think that maybe number 8 and 9 will have a lot of debate as they're used for probably different symptoms. So I had a chat with Mike Walsh in Montreal, and we're hoping to meet up this month in Toronto, since he's running the whole symptom management project with CanSolve, and how we can maybe incorporate those last 2 into his project and part of ours. And not that they shouldn't be used, but maybe that the biggest piece of this is, you know, we should do a really good job at reassessing their use after we do start it, and maybe we can stop them if they're not working or doing what they're supposed to be doing. So more details to come. I just have an example of our algorithm for PPIs up here. You can see it's quite detailed. This is the one that they've used in the Canadian Deprescribing group. This one was developed out of our hospital, out of our family healthcare team as a residency project about a year or 2 before I had done our Deprescribing project in the dialysis unit. This is fine-tuned to dialysis patients. If you go to the next slide, you can see there's an algorithm, but there's also work to go along with it. So you're going to assess symptoms and educate the patient. Since we realize that's half the battle, patients realize that they can restart a medication. It does make them feel better about trying to stop a medication. I think it's always worth trying to stop, because you never know if it really was working or not. And then the detailed outline of how to our Deprescribing trial, and that goes on to the next slide as well. So you can see that each of these medications is quite involved in the process, but it is part of usual care as you're following up on symptoms, and if, you know, certain medications are working. So I think that's the bonus of this type of algorithm, is that it can be incorporated into your daily routine practice. So back to my objectives. So the last one would be the modified Delphi approach of these algorithms, and maybe the next time I present, we'll have an update on that. So I'm happy to take questions if anybody has any.
Hi, Marisa. It's Heather.
Hi.
I have a question for you. It's great to see you last week. Thanks for your presentation. Really interesting. I just wondered if you could talk a little bit about the patient perspective and how patients feel about being deprescribed, and whether there's a certain level of anxiety or just how they feel.
Yeah. Actually, you know what, Graham, if you can just go up a few slides. I have extra slides. So it's a great question. So I debated to go back and ask patients about the study, but they weren't going to remember. So this is some information that I thought would be interesting. So this is to do with the reasons why for the main part, we didn't use the algorithm in the patient, or either the patient refused or the physician refused. So this is, for instance, number 16 that's the diuretic one. So this is, even though our physicians agreed on the algorithm, in the end of the day, they started to worry, maybe we should just keep it on. So that was a big number of patients. Patients anxious about stopping, only 3 of them So that was quite positive, I thought. They were willing to stop. I think the biggest piece was if we told them that if, you know, they had any symptoms that would come back, like symptoms such as a PPI, that they could go back on the drug, or we could try different drugs. So we were thinking H2 blockers. That was part of the algorithm. They were okay with trying. I think they don't want to be on as many medications as they're on. So we really didn't have any issues with this pilot. I don't have this information here, but we did a falls trial. So patients who are at high risk of falling, we reviewed their medications. It's a separate project. And we had algorithms for antihypertensives and psychotropic drugs. So the antihypertensives was easy. Patients, physicians agreed to, you know, listen, the blood pressure's falling, maybe we should stop one of their antihypertensives. No problem. When it came to benzodiazepines, the patients refused to stop. And so I had that student who had implemented those algorithms go back and ask the patients why. And what came out of it was, you know, they don't sleep well, they need something. I didn't know that you could use something else. I didn't know about other things that we could try. So there was a bit of resistance, but also a little bit of the idea, well, if you try to tell me that there's other things, I agree with the physician. I trust the physician. So I am willing to try, but I need to know more. So I think it depends on the medication at the end of the day and how hard it will be to stop. So you saw benzos was part of our algorithm list that we will develop an algorithm for, but I presume that will be the hardest one to stop. The other ones are a little bit more black and white.
Interesting. Yeah, thanks for that. I do have one more question just while I have my...
Sure.
There must be a strong economic case for this, and just wondering how you've woven that in. Yeah,
so we have, I didn't show you some of the polypharmacy data. So when we did the database analysis in Ontario, PPIs, as you saw, was quite high up there in use. And just to give you an idea, over a 3-month period, we had spent $150,000 just on PPIs.
Wow.
So it would add up after a year, and these are all chronic use medications. So yes, there is that piece of it as well. Obviously, the patient's well-being is the first and foremost, but there is the cost piece that comes along with it as well.
Yeah, interesting. Great. Well, thank you. Are there any more questions for Marisa?
It's Victoria, and I joined late, so thanks for the presentation. You asked 2 of the questions that I'm not, at this stage in the day, I'm actually not thinking very quickly, but thank you, Heather, for asking 2 questions that I should have thought of, which you did. My other question, so the question that I'd like to ask is, so Marisa, just for my edification, so, and I think we might have touched on this when we had our brief conversation last week, but so who is doing the prescribing of these? Is it the nephrologists, or is it's the GPs in some cases?
Yeah,
right?
It's a great question.
Or it's mainly all GPs?
No, it's a great question. So we actually looked at that demographic data with our Ontario database. I didn't show you all the results. And it was about 50-50. Cardiologists were in there, but very, like a couple %. But essentially, it was either the general practitioner, the family MD, or the nephrologist. So I think, from my practice, is that often the family physician would start, and then the nephrologist would write repeats. So it really is 50-50. And from my experience, you know, many of our patients don't go see their family doctor in the hospital 3 times a week, so they'll see the nephrologist, you know, the fellow, the nurse practitioner, and it's probably easiest to deal with them than trying to make an extra appointment to see their family doctor. That's my practice in Toronto, but I presume it's pretty similar across the country.
And so that's helpful, thank you.
Yeah.
And so in terms of what is your thinking, or is it too early to be thinking about what's the knowledge translation vehicle for actually affecting practice?
So I guess it's twofold. When we did our pilot, we actually informed the family physician. We wrote a letter to them. So we either emailed it, faxed it, depending on the family physician. So they were aware that we had implemented this algorithm and stopped one of their medications or two of their medications. So that's one piece of it. I think deprescribing outside of nephrology has become even is out there, and so you see a lot of it in the geriatric world, and choosing wisely. So I think between the, from the outside nephrology world and then our work, I think the knowledge translation will just happen. I haven't thought about it as in much detail at this stage, but I guess when we have to implement, it will be, one of the first things that we need to think about. And I think that will even come out when we do our national consensus, asking about the implementation of these algorithms.
Yeah, interesting. I think I would have been thinking about it anyhow, but I was just looking today at the Therapeutics Initiative latest letter to the GPs in BC, which is on the topic of medication reviews and just what the evidence says, and it's obviously it's about reducing polypharmacy, so it's not specific, but yes, absolutely, it's great that it's an area of important discussion. So I'm just I'd love to see how it actually once the work is done, what the vehicle sort of changing practice could be.
Right.
Very interesting. Thank you.
No problem.
We've had another question from Helen via the chat window. So she's asking about involvement of patient partners and whether or not that's changed how the study is developing. Yeah,
it's a great question. So we had three patient partners in the room last week. One has been part of this for a number of months, about 6 months, and then we recruited Leah back, I guess, in March. And so it's really interesting. So, of course, they are very positive. They both had experience. For her, it was her mother. For Blair, it's himself. With going through being on, a list and list of medications. The one struggle is that for Leah, she said, I don't know these medications at all. I can't even name some of them. So it definitely has made me step back to make sure I explain, that we all explain sort of their indications, some of the theory behind why they're used and why they wouldn't be used. For them, it's really quality of life and being on less medications. So that's the big picture. So in some ways, it's, I always have to step back to remember, it's complicated. Taking medications is really complicated. It's easy for me to understand it because that's what I do every day in my life, and I've studied it for many years. But, for the patient, it's very hard to remember even what one drug is and what time to take it at. So in that respect, it's really made me step back to really appreciate that piece of it. Helen, I'm not sure if I've answered your question. Yes, thanks. Okay, I see it. Thank you.